Welcome to the Health System CIO show. I'm your host, founder, and editor-in-chief, Anthony Guerra. On today's episode, I'll be speaking with Dr. Thomas Keane, National Coordinator for Health IT in HHS. Dr. Keane, thanks for joining me today.
Thanks for having me, Anthony, and I'm going to insist that you call me Tom.
All right. I can do that. I can do that. Thank you, Tom. Let's start off. You want to tell me a little bit about the organization. I guess you don't need too much about that, but there's been some changes in structure, where you're under, where you've moved to, responsibilities that would be of interest to our audience. And so first tell us what the changes are, and then sort of any, if any, practical effect that you would want our readers to know about.
Yeah, well, thanks for the question. I'll give your readers and listeners, for those who don't know, 1 minute on ONC. You know, we were founded by presidential executive order in 2004. In 2009, the HITECH Act actually gave us a real legislative basis. And the initial responsibilities of the organization were to help with the rollout of electronic health records. And in 2009, only about 15% of providers nationwide were using electronic health records. Today, it's probably upwards of 95%. And really, in the first 5 years, by 2015, we got the adoption up to about 90%. We administer the Health IT certification program. We administer the TEFCA exchange network. And we administer the information blocking regulations that say that data has to flow for the benefit of the patient at the direction of the patient. So that's a little bit about the agency that I have the privilege of leading right now. As you know, recently we went from being the Assistant Secretary for Technology Policy back to the National Coordinator for Health IT. And the reorganization, which happened right at the end of President Biden's administration, brought a number of internally facing functions into the organization. So the Chief Technology Officer, Chief Artificial Intelligence Officer, and Chief Data Officer were all brought within the organization, and ASTP became responsible for managing the health systems architecture, health data strategies, and other functions internal to HHS within our organization. This came really without any legislative remit, without any additional funding or people. And we felt when we landed that this had us have a diffused mission. Traditionally, we had focused exclusively on external stakeholder engagement and making sure that the external world of health information technology worked. And we didn't feel that it was necessary for us to manage all of the internal technology, all the technology internal to HHS. So as soon as I landed, I believe myself, my friend, the Chief Information Officer, Clark Minor, and the Secretary's office, as well as the career staff here, were all on board with undoing the reorganization. In point of fact, it was never operationalized. When I landed, the 3 functions that had been brought within our agency were actually still reporting to the Chief Information Officer. And so I don't think anybody in the market is going to see any difference in the functioning either of the department or of ONC. We're going to make our focus external stakeholder engagement and making the market work. And my colleague, Clark Minor, in the Chief Information Officer's office is going to work on internal systems architecture, data policy, artificial intelligence policy, and the like. Your CIOs, who are your listeners and readers, are not going to see any difference.
Yeah, so it made more sense than you said. There were no additional resources allotted for this extra mandate. And so, hey, we're either going to try and get the resources or we're going to get rid of the extra mandates.
Yeah, I think it works better this way. You know, in order to manage functions across the agencies at HHS, you really need to do that from the Secretary's office and from the immediate office of the Secretary. You know, the CDC is in Atlanta, FDA is in White Oak, Maryland, CMS is in Baltimore, Maryland. You know, to align information technology policies across these agencies, which have their own statutory remit, their own needs, their own locations, their own staff, that really needs to be managed from the Secretary's office and really needs a fair amount of authority, resources, funding, and the like. And it was never well seated, I don't think. within ONC. And we really do enough with focusing on how external stakeholders and the market more broadly function. And that's what we're focused on now.
All right, excellent. Let's talk a little bit about, well, let's talk quite a bit, maybe a little bit, about TEFCA. Um,
Sure.
Hundreds of millions of records exchanges. We've got this two-lane approach, TEFCA and what
Mm-hmm.
we call the CMS-aligned networks. Um, so I guess anytime you may have to participate in two things instead of one, uh, people would want to ask why, if it takes extra effort to do both, is that necessary?
Mm-hmm.
So what can you tell us about that two-lane approach, why it's necessary, help people understand, and any advice you can give them on doing that in an efficient way?
Yeah, so Amy Gleason and Amy is running up the CMS-aligned networks and the CMS health tech ecosystem efforts. And Amy and I have talked about this in a number of public forums. The CMS health tech ecosystem effort is a accelerator effort. They are trying to solve problems that plague health information exchange and the use of health information technology. In an accelerated collaborative fashion with by participation from actors in the market who've taken voluntary pledges to develop and align with standards and functionality that people come up with collaboratively. And at ASTP, or now ONC, we're taking a regulatory approach. We instantiate all of the operating procedures in TEFCA through a collaborative approach in which there's voting, in which all of the participants, sub-participants, QHINs, and technical people all agree to the QHIN technical frameworks, the common agreement, the standard operating procedures, and update these according to a standard process. Similarly, the information blocking rules that govern networks and the certification program are all instantiated in regulation. What the CMS health tech ecosystem effort is doing is accelerating solutions to problems that we face in our programs and that CMS faces in their programs. And as these solutions mature and develop, we can adopt them into our programs and CMS can adopt them into their programs. So over the next couple of days, I probably have a half dozen meetings with my CMS colleagues to talk about alignment and to see how we can make sure that we are leveraging each other's approaches. I don't think that there's a sense that there's dual participation. For example, all of the qualified health information networks on TEFCA also participate in the CMS-aligned networks initiative. So, for example, as the CMS-aligned networks come up with a record linkage approach, we can look at that in TEFCA and then vote on it and adopt it as an approach to record location and record linkage services, things like that. So I don't think that anybody should have diffused attention. We, of course, encourage everybody to participate in health information exchange through whatever platform works for them. And what we found is that the folks who have moved on to TEFCA have found it to be robust and functioning well, as is demonstrated by the fact that in just, I think, the last 9 months, we've had over 700 million new documents exchanged among 78,000 participants now.
So you see the CMS aligned network and what Amy Gleason's doing, mentioned an accelerator. You see ideas and technologies and workflows coming out of that can be adopted and replicated in TEFCA and other places. Is that kind of what?
Correct. And so, for example, a national provider directory, which is one of the initiatives they're working on, can be leveraged by everybody. A robust national provider directory is useful to everybody, not just who work in health tech, but to every hospital and every payer in the country. And they're really working to get a robust, up-to-date directory and a method for maintaining it. And that is something that we can leverage when it's fully mature. And from what I understand, they're doing great work on it. Similarly, as I spoke about the record location services, or as you'd call them, traditional database work, record linking strategies. As they come up with methods to reduce the number of collisions and to allow for unique identification, we can consider those for adoption in the networks that we administer. And frankly, anybody who runs a health information network can consider leveraging that work.
Yeah, and you also seem to reference a difference of they've got more of a voluntary thing going on over there, and a lot of the things you do are more statutory regulatory. Is that correct?
That's the approach we're taking. And, I think Dr. Oz's and Amy's vision is that in addition to the regulatory lever that government can pull, there's also the convening lever. And Amy is really focusing on that convening lever, getting people to voluntarily pledge. I think they now have 600 or 700 pledgees, all working towards a common goal. They're all collaborating in Slack groups, online and offline. They're meeting. And I think tomorrow, actually, Amy's going to be demonstrating some of the minimum viable products that some of the pledgees have come up with. And it's very exciting.
All right, very good. Regarding TEFCA, there's some concern on the provider. I talked to a lot of these folks, and there's concerns on the provider side. There's some issues that have come up that have been in the news. Some of them are in the courts. There was a letter 40 health systems wrote to the Sequoia Project asking for stricter onboarding. There's been some incidents and there's some concerns about the vetting, the entities that are accessing or can access TEFCA. The health systems, they're very, and this is what you want, right? They're very concerned about their records and patient privacy, sort of for many moral reasons, for regulatory reasons, for legal reasons. They take it very, very, very seriously. And a few incidents have made them very concerned about this, the network, about TEFCA, and maybe some of the other ones. So what would you want to, there's that letter. What would you want to tell them that is being done or has been done to allay some of those concerns?
Well, let me start with saying I can't comment on any particular piece of legislation or letter. It's not proper for us to get involved in that. But what I can tell you is that by its very nature, health information exchange, like any sort of networking or information exchange, is going to require continuous updating and continuous modification of the terms of participation, the standard operating procedures, the cybersecurity posture, and everything else. And we have the ability, both here at ONC and through the recognized coordinating entity, to adapt very quickly to occurrences in the market. So I would say the first thing that people should understand is that this is a government-administered network. And what that means is if there is inappropriate behavior on the network, the government has the ability to actually correct this. So if inappropriate behavior or fraudulent misrepresentations of exchange purposes occur, it's not simply a complaint to a court or to a counterparty. It's also a complaint to government. And we have the ability to actually enforce laws and take legal action, law enforcement action against people. And that's one of the great strengths of TEFCA. So as incidents occur, I speak with my colleagues in the Office of Civil Rights. I speak with my colleagues at the Department of Justice, and I speak with my colleagues in the Office of General Counsel and say, maybe there's something that needs to be looked at here. That's first. Secondly, all of the governance procedures and all of the agreements in TEFCA are legally binding assertions of appropriate exchange purposes. The development and governance is completely transparent. So everyone knows and can contribute to the development of these operating procedures. And that's another thing that makes TEFCA very unique. Additionally, we are taking seriously what the providers are telling us, and we are looking at creating additional requirements for onboarding and additional vetting procedures, and we're introducing these to TEFCA and to the QHINs. And as you know, there's already existing security measures. You know, people have to carry cybersecurity insurance. People have to do annual penetration testing. There's an exclusion on using the records for insurance determinations, employment determinations, and credit determinations and the like. Now, if there are bad actors out there, we have the advantage that being the government, we have strong correctives that we can take against them, which is unique to a government-administered network. And we are taking very seriously all of the input from folks who participate in TEFCA, as well as we allow public comment from people who don't participate in TEFCA. So,
yeah, it's just an interesting dynamic. There's the requirement, the push to exchange data, the need. You have to exchange data, right? It's not a choice, it's not optional. You have to do it. You have to join these networks. And so you understand that feeling on the other end when it's like, whoa, 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 right? So to know by what you're saying, you sound very sensitive to this issue, and that they should know that this is being taken very seriously, and things will get better. Is that fair?
yeah, 100%, and they'll get better sooner rather than later. And, you know, the reality is on any health information network, these issues, or any information network at all, the internet, these issues are going to arise. And over time, we can make sure that the target is hardened, make sure that the participants are all behaving appropriately and in keeping with the agreements that they've signed. And again, I'll just emphasize, most importantly, we have direct access to law enforcement and direct access to the Office of Civil Rights. And so, for lack of a better way of putting it, we have a pretty strong whip hand in making sure that people are actually compliant with their legal obligations. You know, there's an inherent tension between the need to protect the privacy and security of patient records and the need to exchange them for the benefit of the patient. And this is going to be something that continues to have to be sussed out in the market. There are technological, policy, and legal solutions to all of this. And but we're always going to have to hem in the edge cases. And we're 100% committed to doing that.
Very good. Now, I don't know if this is too much in the weeds, just tell me and we'll skip it. But, you know, there's a desire for more visibility into what happens with the data when it leaves the system of the health system and goes into the exchange. You have any thoughts on that?
Yeah, you know, audit trails are, you know, first of all, I believe a requirement of the HIPAA security rule. And secondly, we hear from the participants in TEFCA that this is something that they're interested in. And again, this being a collaborative voluntary network, we can very quickly hear these needs, and we can look at how we can implement them very quickly. I'll just say that. That's the beauty of having the government as a convener and having a recognized coordinating entity that reports to the government, that allows us to architect the solutions that people are interested in. Now, the reality is, once the data gets into the patient's hands through an individual access service, the patient is free to do what they want with their data. And we just want to make sure that the patients are informed, that they know what's happening to their data. Generally, what we found in our engagement with patients is that patients are pretty aware, and that if it helps their healthcare and if it helps them manage their healthcare, they're comfortable sharing that data even with people other than their physicians. And that means with their caregivers or with an AI chatbot. We just want to make sure that the patient is informed, and that's part of our focus.
All right, excellent. Let's switch gears a little bit. There was a diagnostic imaging RFI. This is an area I know you're well practiced in, and I've always been very interested in imaging. It's a fascinating area. The general move, attempted move at many health systems, or not many, but a number of health systems, from radiology focused and siloed imaging to more of an enterprise imaging paradigm. which you see at some health systems, although it doesn't have the degree of uptake that I would have expected a few years ago. I just think it's a massive, massive project, and um, maybe what's working now, it's okay, just leave it alone. There are lots of other things to worry about, but you do see some health systems really taking this on. There was a diagnostic imaging RFI that ONC put out. What are your thoughts on sort of traditional imaging, where we are with imaging as an industry, and where we want to go?
Yeah. Well, I guess I can say two things about imaging. First of all, by way of background, imaging is probably the backbone of diagnosis in hospitals now. Obviously, dermatologists don't use imaging, but virtually every other specialty, it is the basis of triage and diagnosis in hospitals, among inpatients and outpatients. It's really become the standard of care. And so and frankly, it's relatively inexpensive and very quick. As you know, when somebody presents to the ER after a car crash, you just scan them head to toe and you're able to diagnose whatever's happened with them. If somebody comes in with belly pain, the first thing that happens to them is a CT. If they come in with mental status change, same thing. And stroke. And diagnoses can be made rapidly. Typically, a report will be back to the emergency room physician even before the patient is back in the room. And so it's really become a mainstay of patient care. There's two aspects of it that we're interested in ONC. The first is the ability to exchange diagnostic imaging, because right now, its importance in the healthcare system means that every patient or nearly every patient needs diagnostic imaging. And what frequently occurs is that diagnostic imaging is acquired in one setting and then needs to be used in another setting. And the question is, how can we make sure that this imaging information is readily available when and where it's needed so that patients don't have to undergo repeat imaging, or so that the full diagnostic picture is available to the physician? And there's challenges to it. Diagnostic imaging technology tends not to be certified health IT. The images are huge. An entire written medical record can be compressed and transported relatively easily, even in a PDF format, whereas diagnostic imaging information can be tremendously large files, and storing and transporting these can be a challenge. And so the reason we put out the RFI was to say, hey, how can we do image exchange efficiently? How can we use our levers, both here at ONC or at CMS or even at the FDA, to make sure that diagnostic imaging exchange happens efficiently? The other RFI we put out was on artificial intelligence, and there's 1,300 software medical devices that use artificial intelligence that are certified by the FDA or have been approved by the FDA. And I believe 85% of them are in the field of radiology. I've actually been using artificial intelligence since 2005, when we were using computer-aided diagnosis in mammography. And we're interested in knowing how we can leverage AI best in diagnostic imaging in particular, but in healthcare more broadly, because there's tremendous promise to AI. So for example, pretty much every hospital I've worked in uses software to triage stroke patients. And pretty much every hospital I've worked in uses fractional flow reserve calculation software to evaluate cardiac CT angiograms. And virtually every hospital I've worked in uses artificial intelligence to evaluate mammograms. And what we want to make sure is that the technology is safe, reliable, continues to evolve, is properly monitored, and frankly is leveraged, is appropriately leveraged. To the extent that it can increase a physician's productivity or accuracy, we want physicians to use this technology. So we put out an RFI specifically asking, what can we in the government do, or what needs to happen outside of government to make sure that AI actually improves the care of patients? And I think we got 7,000, either 4,000 or 7,000 individual comments. So we're going through that now.
I assume we have AI helping us go through those comments. That's what I would do.
Well, I will tell you the truth, we do. But we actually have a human being read them individually. Each and every comment gets read by a human being. So
Nice.
it's the nature of the beast. I will tell you the truth. We found that the AI summaries don't always capture the nuance of the comments. So, but I think we're probably constrained anyway by law to actually have human beings look at each comment. So if we're going to ask the public to contribute, we want to make sure that we're taking it seriously.
That makes sense. That's very good. Um, how do you think your background in radiology is helping you do your work today at the ONC?
I would say my background as a physician, I continue to practice, is probably one of the most important aspects of me being able to do this job properly because I understand what actually happens in the market, how care is actually delivered and received, what the pain points for patients, physicians, and payers are because I lived within the system, or I've lived within the system now for over 25 years. And so I'll give you a concrete example. We have a certification criteria called two-factor authentication. And the certification criteria asks, do you or do you not support two-factor authentication? And interestingly, you don't actually have to in an electronic health record support two-factor authentication. So about half of electronic health record providers do, and about half do not. When we contacted the half that do, we asked them, how often is this deployed in the market? You support it, but how often is it deployed? And the reality is it's almost never deployed. And it's obvious to a physician why this is the case. And it's because checking on your phone every time you get an automatic logout on your computer doesn't really work if you're in gown, gloves, mask, and cap, triaging a patient in the emergency room. So when the regulation was originally written in 2015, there was a desire to make sure that there were security features in the electronic health record, but this is a particular security feature that doesn't really work in physician workflow. And any physician, any practicing physician or nurse or allied healthcare provider can tell you, yeah, there's no way I can wait for a text on my phone in the radiology department where all the walls are lined with lead and you don't get any signal. It's just not a practical approach to cybersecurity. So hospitals have actually implemented other approaches to cybersecurity, typically global approaches that work for all of the applications they deploy. And so to understand that when we're evaluating what really needs to and doesn't need to be in the Health IT certification program, it's helpful to actually have the clinical background. So, and frankly, I still love practicing medicine, and I intend to do it until either I drop dead or they tell me I can't do it anymore. So, yes, we just met with a large technology company that's getting into the healthcare business, and they said it best: healthcare is hard. Every aspect of the economy has been completely transformed by network computing. Right, network digital computing has changed the world over the last 30 years. And computing more generally, even before that, changed the world. One area that has been particularly tough to penetrate has been healthcare. And yes, we have electronic health records. Yes, we have PACS systems. Yes, we have robotic dispensing of pharmaceuticals in hospital pharmacies. But the reality is the promise of networked computing hasn't been fully realized yet. And that's because healthcare is hard. And I think being a healthcare practitioner who's overseeing its regulation is an advantage.
Yeah, it's a great point. The understanding that you have leading the department that you lead, being a physician, is absolutely essential. So for our audience, it's a little bit of a different dynamic. They're leading the IT efforts at the health systems, but most of them are not clinicians, and they never were clinicians. They came up through IT.
Mm-hmm.
Sort of one of the identified best practices is to make up for that, they need to be as close to the operations as possible. They need to understand as much as they can about the operations, spend time on the floors, spend time in the hospital, develop those relationships, because otherwise you wind up expecting a surgeon to do two-factor authentication, right? So you don't want to
Right.
wind up down that road. And the way you do that when you aren't living it is to get as close as you can. So as a doctor, what do you want from, let's, in the hospitals you've worked in or do work in, what do you want from the IT professionals leading those places? What kind of understanding or relationship do you want from them?
That's an excellent question. And let me first say my apologies to all the CIOs out there for having to deal with physicians. We are a tough lot. I was the CEO of a medical group for a while, and I've learned that managing physicians and collaborating with physicians on anything other than direct patient care can be challenging. So my hat's off to the folks who do it. I think just what you said, that involving physicians and nurses and the entire care continuum in your decision making on IT, on IT workflows, on the IT you purchase, on how you select and deploy artificial intelligence, and just staying close to us. I know that it's not easy. And in my experience, though, the CIOs have been real princes, real gentlemen and gentleladies about how they've engaged with the provider community. I think one of the early criticisms of the way EHRs operated in the first 5 years that they were really adopted after the HITECH Act is that they were purchased by hospitals who were focused on revenue cycle management. And so the EHRs were optimized for revenue cycle management. Let's get billing and claims correct. And then not surprisingly, this created a lot of provider burden because it wasn't necessarily optimized for clinical workflow or provider experience. And so in 2016, Congress passed the Cures Act, and one of the specifications of that piece of legislation is that government has to reduce provider burden associated with the deployment of EHRs. So to the extent that that disconnect between what the C-suite is interested in and what the frontline practitioners are interested in, to the extent that that can be narrowed, I think we're all better off. For what it's worth, I'm sympathetic to the CIOs and CEOs who, under meaningful use, had to rapidly adopt EHRs and had to make so many decisions so quickly. It actually went off pretty well. I mean, we really went from 15% to 90% adoption in about 5 years. So it's to the credit of, your listeners that this was able to happen. And then I appreciated the pivot towards usability and clinical support. And just to keep talking on it, right now we see that AI scribes have been widely deployed. Even though they're costly, physicians love them. They actually don't save physician time. They allow physicians to repurpose their time towards patient care around from administrative tasks. And it really shows how much the C-suite has evolved in that they're willing to spend money, precious hospital money that could go to anything, another CAT scanner, a new operating room, a new maternal health center, and they spend it on AI scribes because they understand that even though there's not necessarily a cost savings for the hospital, that it actually improves physician workflow. And so I think that's a perfect example of the collaboration working.
Yeah, it's fascinating to see sort of how technology has impacted care over the last 10 years or so. As you mentioned, with meaningful use, EHRs were rolled out, but clinicians, physicians especially, became responsible for a lot more inputting of data than they'd ever been before, right? It used to be they didn't do that stuff. And then all of a sudden we have to do all this stuff that takes me away from the patient. I want to be taking care of my patient. And now, as you mentioned, with ambient listening, it seems like we're on the verge, probably for multiple reasons or other things that are happening, but we're finally leveraging technology to take things off of the physician's plate so they can be with the patient. I've heard this in a number of interviews recently about humans taking care of humans, bringing the humanity back. We're using technology to bring back humanity, which is kind of ironic, but what do you think? Does that make sense?
It makes 100% sense. And that's really what we're seeing, particularly in the AI scribe market. It's wonderful to be able to look at your patient and simply interview them and have a structured note produced for you. And even more, the structured note pulls out the orders that you need to enter, populates the allergies in the EHR, and figures out what billing codes there are and does the proper, collects the data that's used for risk stratification in the various incentive programs. And you can focus on the patient while the technology takes care of the administrative tasks. And, it's a credit to my predecessors here, to my colleagues who work here full time at the agency and have for decades, and to the CIOs who are your listeners, that the system has finally matured to a point where real returns on the initial investment in technology are being realized.
Yeah, it's just this listening, this humanity, this listening. It's interesting in my work too, talking to you now, the fact that this recording is being captured and I can use AI to help me extract things from it means I can listen to you. I can do a better job of listening to you because otherwise I'm jotting notes at 100 miles an hour trying to capture everything. So it's the same thing with a clinician encounter with a patient. They can listen and be in the moment better, knowing everything they're hearing is also being captured. The human brain can't
Mm-hmm.
do that many things at once, right? At least mine can't. I can only really do one thing at a time. And even though I
Yep.
pretend I'm listening to my wife when I'm doing other things, sometimes I miss a few of the things she says.
I bet your wife knows what you're up to, by the way. Um, so, yes, and a lot of the communication between people is nonverbal.
Mm,
It's not just the words. And when you're sitting there jotting down notes, you might be missing some of that
yeah.
nonverbal communication. When you're actually letting a machine take care of that for you, you really get a more rich experience of what the patient is trying to tell you.
So what's
And
next?
as you said,
Oh,
it's
go
sort
ahead.
of
I'm sorry.
ironic.
Yeah.
I like the way that you put that. It's sort of ironic that technology is humanizing the practice of medicine. Who would have thought?
Yeah. Yeah. I mean, that's just the beauty of it. What do you think? Put on your futuristic hat. What are your thoughts either on what you're going to be doing there at ONC, what's coming down the pike, or just your thoughts on this? Everything's going 100 miles an hour, 100 miles an hour with
Mm-hmm.
this AI technology. I mean, it's amazing. So it's almost like strap on. It's going to be a wild ride. You have to be ready for change. You have to be flexible. You have to be willing to fail fast. You have to be willing to try things. But here's the other thing, you cannot waste clinicians' time. So this is another big thing, which is if you're rolling out pilots in a health system, you're trying new things, you need physician engagement. You better have done your homework because if you
Yep.
lay an egg out of the box, they might not come next time. They're busy people. So you said you guys are difficult to deal with.
Yeah, not my colleagues. My fellow physicians are going to hate me for that, but I think we all know it to be true. I'm copying. I'll plead guilty. Um, the first thing you talked about, you have to make sure that you don't waste the physician's time. You also have to make sure that the patient is safe.
Mm,
And one of the things we're thinking through here as a department is how we make sure that AI is secure and safe for the patient. And that will create trust among medical professionals, which will allow them to adopt and leverage it appropriately. And so a little bit of the way we're thinking about this, as we think about risk stratifying the technology, we think about autonomy. To what extent is there a human in the loop? And then we think about criticality of the decisions that the AI is making. If the AI is kind of coaching you over a long period of time about how to lose weight, these decisions are not necessarily critical, and it's telling you what you can eat or how much sleep you can get at night or helping you track it. That's different from a stroke detection algorithm that gives me about 5 seconds to determine whether this patient is actually having a stroke or not. So we think about the criticality of the decision when we think about how to regulate it, and we think about the autonomy. Is there a human in the loop? And so for something like a mammographic interpretation system, if it's cueing me about what to look at more carefully or giving me an idea of where there might be a cancer that I might not otherwise detect, I'm still there to exercise my judgment. And so a little bit about how we're thinking about regulating AI falls at least in those two dimensions. we want to make sure that it's safe. And then, we want to make sure that that AI is developed in such a way that it can have a positive return on investment. Because even if an AI does wonderful things, if there's no pathway to adoption, if the people who would be the presumed users of it don't see value in it, then it won't be adopted. So we ask that question of the market, and we're seeing what the market says and about how we can help facilitate that.
All right, very good, Tom. That's about it for me. Is there anything we didn't touch on that you want to cover?
No, I can tell you, I guess, in three short buckets, what we're focused on at ONC. We're focused on data liquidity. We want data to flow for the benefit of the patient at the direction of the patient in a private and secure manner so that it empowers the patient. And this means that when a patient is getting treated in a new treatment facility or is being discharged from a hospital, that information follows them. It means that if they want their data on their phones so that they can leverage it for a health maintenance app or so it can help them manage their health in some form or fashion, we want to make sure that data flows to them. So data liquidity is our first pillar. Our second is affordability and access. As you probably know, over the summer, we adopted a regulation to require electronic health records to display in real time the estimated costs of a patient's prescription, so that a patient, when they're with their doctor and choosing what pharmacotherapy to implement, they know not only what the effective therapeutic alternatives are, but what the cost of each of those alternatives are, so that the therapy can be optimized not only for efficacy, but also for affordability. So affordability and access is one of our focuses, and we've taken a giant step forward by requiring that real-time pharmacy benefit determination functionality in EHRs. And then finally, technology evolution. We want to make sure that our certification program and that the TEFCA network that we administer and the Health IT alignment programs that we administer and the data interoperability programs that we administer all look at the evolving landscape of technology so that we're keeping up with AI and keeping up with the latest and greatest that the market has to offer. So those are our three buckets for your listeners who are interested.
All right, Tom, this was a great chat. I thoroughly enjoyed it. And I enjoyed
Me
seeing
as well. Thank you.
I enjoyed seeing you at the conference. Was it the HIMSS conference or the Vive one? I think it was HIMSS, right?
I think it was
Yeah,
probably him. Yeah.
yeah,
Vive, it was a quick turnaround for me.
right. Well, it was wonderful. I appreciate your time, and I hope we can catch up with you again down the road.
Looking forward to it. Thank you for having me.
Have a great day.